Hi, I'm going to be continuing my video series now with, finally, the central mechanisms considered to contribute to phantom pain development. So unlike the other central nervous system theories that I've discussed so far, so just a quick recap, the neuromatrix and the pain memory theories, the theory of incongruence is considered to contribute to phantom pain development. This theory refers to the incongruence of proprioception, motor intention, and visual observations in individuals with missing limbs. The brain is constantly sending efferent signals to the body and constantly receiving information on how the efferent signal was executed. So my brain is telling my arm to move, and when my hand moves, it's returning a signal back up to my brain telling, yes, indeed, my hand has moved. But with amputation, the efferent or motor signals continue to be sent, however, they are not properly delivered, and an incongruence develops when the afferent signal does not tell the brain what it was expecting. So various treatments have been developed to reduce this incongruence. One example is mirror therapy, which is outlined in the treatment section of my video series. Support for the role of incongruence in phantom pain development comes primarily from a study done by McCabe, Hay, Halligan, and Blake, which they did in 2005. This study introduced incongruence to healthy patients and evaluated the consequences. Although this was not a controlled study, which is pretty much the gold standard of research, researchers found that incongruence produced abnormal sensations. The mechanism by which incongruence causes changes in the central nervous system is not well understood, but enough support has been generated to merit the inclusion of incongruence as a factor contributing to the development of phantom pain. Spinal cord modifications are another example of central nervous system changes that are currently considered to contribute to phantom pain. After amputation, a phenomenon termed central sensitization occurs in some amputees. Central sensitization refers to the increase in excitability of neurons, decreased inhibiting processes, and anatomical changes in the spinal cord. This sensitization process occurs because of the noxious stimuli produced by the amputation and is mediated primarily by NMDA receptors. Various neurotransmitters also contribute to central sensitization, such as substance P, neurokininins, and tachykininins. Not sure if I'm pronouncing those right. In central sensitization, innoxious afferent stimuli begin producing a noxious response. So what you have normal stimuli occurring, and you have it being almost transposed into a stimuli that is extremely painful when it was not meant to be painful. Another contributor to central sensitization is the anatomical changes in the spinal cord. With amputation, afferent C fibers degenerate in lamina 2 of the dorsal horn, which normally deals with nociception. This leads to a sprouting of mechanoreceptors, which normally concern themselves with innoxious stimuli, into lamina 2. As these fibers sprout, they produce significant changes in the anatomical structure of the spinal cord. Changes in the architecture and function of the spinal cord alter the way information is processed en route to the brain. So how do these functional and anatomical changes that I've just discussed influence the development of phantom pain? To actually fully understand how central sensitization leads to the development of phantom pain, we must also consider cortical reorganization. Cortical reorganization is another example of central nervous system plasticity, which is an incredible phenomenon that occurs and simply baffles quite a few scientists today. In conjunction with spinal cord changes, cortical remapping can provide a plausible mechanism for the development of phantom pain. After amputation, significant cortical rearrangement occurs, so the cortical zones that once process information regarding the amputated appendage become invaded by neighboring areas. The most significant evidence for cortical reorganization comes from our functional MRI research. This research has demonstrated that nearly all amputees undergo significant cortical rearrangement. Moreover, there exists a direct relationship between the intensity of phantom pain and the degree of cortical homunculus reorganization, both somatosensory and motor. Cortical remapping implies that a stimulus in neighboring cortical areas can produce a feeling of stimulation in phantom pain. So this, in conjunction with central sensitization, which I just discussed, explains how innoxious stimuli from other areas of the body can now become painful in the limb that does not exist. Therefore, central nervous system plasticity across the neural axis provides a plausible mechanism for the development of phantom pain. However, the subtle effects of the other mechanisms must not be ignored. So we looked at psychological and peripheral factors and how they've been shown to have a regulatory effect on phantom pain. So therefore, they are extremely useful in clinical situations. So in my next video, I'm going to continue on to discuss treatments for phantom pain.